We will now move on to hot swollen joints, septic arthritis. Septic arthritis is an infection of any kind that finds its way into the joint space. It occurs because synovial lining has no basement membrane. It is relatively loose, and both bacteria and antibiotics easily find their way across it. Septic arthritis is rare in an undamaged joint, and the risk of infection is directly proportional to the degree of joint damage. Osteoarthritis provides a slight risk. Rheumatoid arthritis, slightly greater risk. The greatest risk is those with a prosthetic joint. Bacteremia can spread into the joint space. This is why patients with endocarditis and injection drug users can cause septic arthritis. The culprits for septic arthritis are as follows. Staphylococcus can be found in up to 40% of cultures, Streptococcus about 30% of the time, and gram-negative rods 20% of the time. A patient will present with a joint, any joint, that's warm, red, and immobile. It will often have a palpable effusion. Patients will complain of chills and fever because of the bacteremia that seeded the joint. The best initial and most accurate test is an arthrocentesis of the joint with a needle. X-ray, CT, and MRI are always the wrong answer and are never useful. The joint fluid aspiration is going to show a leukocytosis with more than 50 to 100,000 cells, predominantly neutrophils. The gram stain will have anywhere between 50% of the time positive for gram-negative bacilli and 75% of the time with staphylococcus. Synovial fluid culture has a sensitivity between 70 and 90%, and the blood cultures are 50% sensitive for the infectious agent that may have seeded the joint. Ceftriaxone and vancomycin are the best initial empiric antibiotic therapy for septic arthritis. Once you have your gram stain, you can then tailor your antibiotics appropriately. If they present to you with gram-negative bacilli, you have the option of treating with quinolones, aztreonam, cefotaxime, piperacillin, or aminoglycosides. If they tell you have gram-positive cocci that are sensitive, you can use oxacillin, cefazolin, or piperacillin with tazobactam. If they tell you have gram-positive cocci that are resistant, you're limited to linezolid, daptomycin, ceftaroline, or tigecycline. As with all antibiotic therapy, you must adjust your antibiotics to the culture results. If staph is sensitive, what's interesting is vancomycin is actually associated with a worse outcome than beta-lactam antibiotics, such as oxacillin or cefazolin. So switch drugs if the organism is sensitive. An infected prosthetic joint will give you a warm red and a mobile tender joint. But remember, without an X-ray or CT scan, you cannot tell whether this infection is limited to the joint space or has already spread into the bone around the implantation of the joint. Bottom line, you must do imaging. An MRI is difficult to perform with prosthetic joints because they're made of metal. If there is lucency around an implantation of the joint on radiologic imaging, or if the joint is physically loose, infection is likely present at the implantation site. It is much harder to clear or sterilize septic arthritis associated with the prosthetic joint without removing the actual joint. Therefore, the first step is to remove the joint, treat with antibiotics for 6 to 8 weeks, and then replace the joint. The most common organism for recently placed artificial joints is actually Staph epidermidis. We will now talk about gonococcal arthritis. For gonococcal arthritis, look for a history of STDs or a sexually active young person. The difference in presentation from septic arthritis, however, is polyarticular involvement or multiple joints. They will have tenosynovitis, which is inflammation of the tendon sheaths, making finger movement very painful. Lastly, they may describe a petechial rash. Keep in mind that gonococcal arthritis is more frequently during the menses. Detecting gonorrhea is much more difficult than detecting staphylococcus, streptococcus, or gram-negative bacilli that cause septic arthritis. When you aspirate a septic arthritic joint, remember the cell count is 50 to 100,000, but with gonococcus, it's only 30 to 50,000. The gram stain is 50 to 70% sensitive with septic arthritis, but only 25% sensitive with gonococcal arthritis. Now you can see why it's so difficult to diagnose. The culture is 90% sensitive of the aspirate in septic arthritis, but it's less than 50% sensitive with gonococcal arthritis. Blood cultures are 50% sensitive for septic arthritis, but less than 10 for gonococcal arthritis. Now you understand why it's so difficult to diagnose. So to reach maximum sensitivity, multiple diffuse sites must be cultured for gonorrhea, such as the pharynx, rectum, urethra, and cervix. How do you know to culture everywhere? If a patient has a rash, tenosynovitis, and polyarticular involvement, don't just culture one place, culture everywhere. Ceftriaxone, cefotaxime, or ceftazexime is the best empiric therapy for disseminated gonorrhea. Fluoroquinolones are not the best initial therapy because more than 5% are resistant. Use quinolones only if the organism is confirmed to be sensitive. If recurrent gonorrhea infection is described, test for complement deficiency. It's a favorite subject of the USMLE Step 2. We will now be discussing osteomyelitis. Osteomyelitis is an infection of the bone. Staph aureus is the most common cause, but any other organism can infect the bone. Children get osteomyelitis through hematogenous spread, but adults get it from a contiguous nearby infection, most often as a result of vascular insufficiency or diabetes. One thing to keep in mind, Salmonella is the most commonly identified organism in patients with sickle cell disease and osteomyelitis. The best initial test for osteomyelitis is an X-ray. The most accurate test is a biopsy. If they tell you the X-ray is normal, the most appropriate next step in your management is to get an MRI. CT scan is always the wrong answer. But what about the ESR? When is it the answer? It is the answer when you want to follow the response to therapy. So you get one at baseline, and then you measure it after antibiotics are initiated to see a response. Here's an example of osteomyelitis on a plain diagnostic film. There are two questions that come up with osteomyelitis. The first is, when is culturing the drainage from the wound the answer? It's actually never. You can never reliably distinguish superficial colonization of the skin from whatever organism is inside the bone causing the infection. The second is when to get a bone scan. You only get a bone scan for osteomyelitis if you want to get an MRI, but it's contraindicated, such as in a patient with a pacemaker. Osteomyelitis takes weeks to progress. Therefore, obtain a biopsy and treat the organism that is found. Without a biopsy, it's impossible to know what organism is present and what is sensitive to. We don't want to subject the patient to too many antibiotics. Sensitive staph are best treated with oxacillin, cefazolin, nafcillin, or ceftriaxone. Resistant staph are treated with vanc or linezolid. Gram-negative bacilli such as E. coli are treated with fluoroquinolones, such as ciprofloxacin, but it's essential to confirm the sensitivity of the organism prior to treating with Cipro. Why is this? It is the only oral therapy for osteomyelitis, but should only be used if the organism is confirmed as a sensitive gram-negative bacillus. We don't want to engender resistance. Fluoroquinolones can cause Achilles tendon rupture from interference with the growth of chondrocytes. They are also contraindicated in pregnancy and in children because they interfere with bone growth. Ladies and gentlemen, that is the end of rheumatology. I hope you've enjoyed our lecture so far in the Step 2 High Yield series. I'll see you next time.